pre-filled. It should be available. There's a vial, I told you, 75 milligram vial by 3 ml. This vial is, yes, this is available. You just take 1 ml out of that. It becomes 25 milligram per hour. Okay, then you dilute it with balanced solution to 5 ml. 25 divided by 5 is equal to 5 milligram. You just take 0.1 ml of that. It becomes 0.5 milligram or 500 micrograms. Yes. So you can inject that. It's very easy to make.
Dichloride comes in 2 forms. It's potassium and sodium.
Right? Yes, sodium.
You take sodium because
yes.
It's more watery.
Yes, exactly. It's more hydrophilic, you can say.
Alright, so this, because as I was thinking that this is probably a news for us.
Yes, exactly.
Because diclofenac has not been as such internationally used or proposed, because the newer treatments do not contain non-steroidal anti-inflammatory to be injected. They are biosimilar, they are other things. But this one is a new product, and I hope if this is a kind of primary research that you are taking, and I hope it ends up, because it's very cheap then, if this really works, then it's quite...
I'm conducting another study, and that is combination of bevacizumab plus intravitreal diclofenac versus intravitreal bevacizumab alone, and to show how much efficacious the combination is as compared to the simple bevacizumab.
Is there any international study for comparison?
Yes, there are certain studies done. This topic is not extensively researched.
Yeah.
This needs a lot of research, and I will encourage all of those who are in the retina field, they should try to explore this drug because it's showing amazing results. And I think it's very easily available, cost effective. The patients, you can give multiple injections, the patient will not bother about that because it's effective, cheap, easily available as compared to the anti-VEGF agent.
Okay.
Thank you.
Okay. So,
just one
any
question.
other? Yeah.
How frequent?
Dr. Aisha?
Yes, it needs to be frequent. Yes, it's important. Monthly is normally the protocol. Sometimes we need to do it bi-monthly. Sometimes, because this is very short-acting, short-lived, and it vanishes. So you have to repeat it. So you have to augment that so as to see the potent anti-inflammatory role of that drug. This is important.
All right.
For inviting me for this session. It's my pleasure. So this is a study that we conducted to look at the safety of simultaneous bilateral intravitreal versus unilateral anti-VEGF injection in an operating room setting. We know anti-VEGFs are commonly used, and one of the risks of anti-VEGF is endophthalmitis, and therefore the question is, should anti-VEGFs be given bilaterally simultaneously? So the objective was to look at the rate of endophthalmitis with all factors being kept constant. It's a retrospective 10-year study design where all the procedures were done in theatre, only anti-VEGFs were used and steroid injections were injected. So in total we had 30,000 injections, of which half of them were unilateral, half of them were bilateral, majority of them being Avastin, because this is the time, the study time is during that time when Avastin was more common. After 2018 our Avastin rates have gone down significantly. So of these 30,000 patients, 4 of them developed endophthalmitis, and this is their data. And this is the incidence of endophthalmitis after intravitreal injection, and this is after bilateral injection. And we have currently the second highest study in publication. So the mean number of injections were 4.2. The international endophthalmitis acceptable published rates for unilateral is, written over there, and in our study the infection rate was 0.013%. This is the largest data analyzed from Pakistan, and it provides international recommendation for safety. As long as the international safety recommendations are followed, it can be a safe thing to do, which is a bilateral. Thank you very much.
Years. A study done was in University Hospital of Colostrum and they said that the survival rate of diabetic vitrectomy was 79% after 5 years. And same study was done in Mooresville Hospital, London, UK, and they said that renal failure was the most common cause of death. And they said that the presence of limb ulcer at baseline was the most important prognostic indicator for mortality. In 2010, a study was done in New Zealand, and they said that 5-year survival rate was 70.1%. And they said that increasing age, dialysis, and higher serum creatinine were associated with poor survival rate. In South Australia, study was done in 2011, and they said that most common cause of death was cardiovascular disease. And the last study was done again in UK, and they said that all cases with known cardiac disease during the management of diabetic retinopathy died within 5 years of their surgical procedure. This is a summary of all these studies. So far, no such study has been done in Pakistan. We are conducting a similar study at our setup regarding the survival rate of diabetic patients undergoing any type of treatment for diabetic retinopathy. This is the proforma which we have made. And so far we have collected data of almost 500 patients, and the results will be presented after 5 years, inshallah. These are the references of these studies. So in the end, treat the patient, not only eyes. Thank you.
Assalamu alaikum. This paper is slightly different, as we are sitting here for the medical retina. But as this peak device also is being used for the retinal pathologies, so it will be interesting for us. This study is about the peak device which was used in the Chakwal area. And here, this is the place where I work, and all the clinical work are being supported by the ME Hospital, Eye Department ME Hospital. In fact, in 2016, Peak Foundation was established in the UK, and they have devised this specific application, and it has two parts. One is the peak capture, in which the smartphone is used and it supports the eye health screening and referral pathway. Second part is the monitoring, and it is a dashboard area where we can supervise and give and see the live updates of the whatever happening in the field and community. And this application, in fact, the first application in Pakistan in which we have performed the screening in the community. It's a very useful thing, and it has three main benefits. One is it is a very handy and paper-free. Secondly, it provides the local service, and the community provides referral pathway, so people can go to the next stage of referral for the treatment. And thirdly, we can monitor and supervise the things, and can see what the people are doing at the community level and how they are performing the screening. In particular, this is a device, as it was a pilot in Pakistan, and we are using at two levels: at community level at the BHU, and at the school with the help of the health nutrition supervisors. And there are three types of referrals. One is the screening by the community workers and the health nutrition supervisor. They refer the cases after the whatever they find that they are the true positive or such things, and they refer to the optometrist level, at the rural health level, where the common eye diseases are treated and the reflection is done. And then their cases are referred to the eye specialist. At each level of the referral, there is a system of the SMS which is delivered to the client, and it is a two reminders, so they can attend the particular referral point, and this message gives the exact place and date when to reach for the particular checkup or to the appointment of the doctor. Once that patient reaches to the doctor and treatment is done, whether it is medical or surgical, then the loop is closed. And all of this cycle of the patient can be monitored at the admin area, which is a hub. College is the hub of the admin support of this application. Of course, the motivation and commitment of the health department and training of the health workers and primary eye care workers is very important. And then these people, they screen the patient, normal people in their workplace, and then definitely at the second level, and they are being examined at the rural health center. We have trained the lady health workers and health nutrition supervisors in primary eye care. We have the people are being screened at the BHU level and at the schools. And the beauty of this application is that now at the rural health center we have the optometrists who are providing primary eye care and the refraction and other things. Not only this, we have given a lot of equipment at that rural health center to help the refractionists to do these refraction and primary eye care. And since the last 2.5 years, we are implementing this project in Chakwal, and in fact it is a 3 tehsil of Chakwal, and till now we have engaged more than 150 radial visitors, and we have appointed 16 optometrists and who are working at the 14 newly established rural health centers and working under this project. This is an example that how beautifully we can monitor each patient and each screened individual, and just see if in this particular case, this is the data.
The NSAIDs, non-steroidal anti-inflammatory agents, what their role is, what the mechanism of action is, what they actually do. So let's just explore. So diclofenac, basically, all of you know, it's a non-steroidal anti-inflammatory agent, and it acts by inhibiting the enzymes COX. We call it COX1, COX2. Basically, they are cyclooxygenase, and these are the enzymes which are responsible for the formation of different sorts of prostaglandins, which are inflammatory mediators. So NSAIDs block this step of inflammation by inhibiting the production of these inflammatory mediators. It has other roles as well. Studies have shown that they can inhibit the neutrophils and the rest of the functions, as you can see. So it is available both in the tablet forms, it is available in injectable forms, it is widely available everywhere, easily available, cheap, cost-effective drug. So you can find it in different concentrations, at different doses, and different injectables are available by different brand names. So you can see these are the different available products here. General use is that it is mainly used in rheumatology practice for different types of acute pains. It may be osteoarthritis, rheumatoid arthritis, different kind of connective tissue diseases. We utilize that as the list you can see here. In eye ophthalmology, we are also acquainted with this drug as well in the form of topical drops, and we are quite familiar with that. And nowadays, new different sort of NSAIDs like nipofenac acid, which is more common in practice in the topical form, and it is used widely in different kind of ocular indications. Maybe we can use it in post-operatively to prevent the cystoid macular edema. Post-operative corneal refractive surgeries, we use frequently this drug to suppress the pain as well as inflammation, and in diabetic macular edema it is used mostly in the topical form in the form of nipofenac acid, which is quite commonly used. And macular edema, as due to other etiologies like retinal vascular occlusions or different kind of uveitis, especially the posterior uveitis, which is notorious for causing this cystoid macular edema. Let's recall some knowledge about the diabetic macular edema, and we can see the pathophysiology is basically the microangiopathy, which is the targeted area mainly. This microangiopathy means occlusion, Rolex formation, thrombus formation, loss of pericytes, extravasation of the fluid, the plasma constituents into the surrounding tissue, leading to build-up of the fluid level, and mostly the area and the capillaries affected is the macular area, which is the most hard area, and this is the most sacred area of the posterior segment. Once this is affected, you know, it can lead to blinding complications. So this is the targeting area, and we have evidence from a lot of studies that the VEGF is upregulated in DME and PDR, and you know the vicious cycle of this inflammatory production. Whenever there is ischemia, hypoxia, it will lead to revascularize, reperfuse that area. In the effort, they try to produce some growth factors. Vascular endothelial growth factor is one of the well-established factor in the causation. Despite that vascular endothelial growth factor, we can also encounter a lot of other inflammatory mediators like prostaglandins, which also play a role. One of the study was published in the American Journal of Ophthalmology in the year 2011, and they show that not only the angiogenic factors, which are upregulated in the diabetes, there are certain other factors which also play a vital role, and these are basically the leukotrienes and these inflammatory mediators. Specifically, if we talk about the prostaglandins. So that's the main theme behind exploring the agent, that if it is really that effective in suppressing the prostaglandins, so either we should utilize it as an intravitreal agent. Already it is established as a topical agent. Why not to engage this in the form of intravitreal drug and see and explore its properties? So that was the main aim, and to see the efficacy against a well-known agent, that is the bevacizumab, which we all know. We have a lot of studies done on this, and this works really tremendously in diabetic macular edema. So this was a standard bevacizumab. This was the main aim. So we did a comparative case series, as the design was definitely comparative to see the efficacy of this newly drug in the form of intravitreal route. So we allocated the groups. One group allocated to intravitreal diclofenac, and one group allocated to intravitreal bevacizumab. The participants were observed for a period of 6 months, quite sufficient time to see the efficacy of this new agent in the form of intravitreal route. So we developed some variables for that. Our primary outcome was the best corrected visual acuity. Whether is it really going to affect the best corrected visual acuity, or there's no effect, or we can see the worsening. So this was the main primary variable. The secondary variable we took was the OCT for the central macular thickness, which is again very important. Structural changes and anatomical changes. Will it really dry the fluid from the macula, or will it cause the worsening, or what sort of? We were unaware of that. So we also evaluated the intraocular pressure to see whether it has anything to do with the intraocular pressure. So we devised the patients, and we made the inclusion and exclusion criteria. We took the patients, included the patients, enrolled the patients based on the ETDRS criteria, which is the standard criteria, and then we excluded the patient, the long list of patients, in order to avoid any sort of a bias in the study result that we are going to conduct. So the results were that we took 25 patients with bilateral DME, and total 50 eyes were there. One group was given the intravitreal bevacizumab, which is a well-known agent, and its efficacy has been proven in a lot of studies, in a dose of standard dose 1.25, and the other group was given the intravitreal diclofenac sodium in the form of intravitreal, and it was given in a dose of 500 microgram, which is from certain studies we established this dose, that this is effective enough for showing the efficacy of this new agent as an intravitreal drug. After 6 months of follow-up, after 24 weeks, we can say there was an improvement observed in the visual acuity, and we can see that both the groups showed improvement, although we observed slight more improvement in the bevacizumab group. Definitely, it's a proven drug, and this was more effective as compared to the intravitreal diclofenac. In both groups, marked reduction in the CMT observed, again, astonishing results for us from the baseline. Again, the difference between these two were statistically non-significant. There was no statistical significant difference, though there was a reduction in the central macula. Interestingly, we observed that the diclofenac group, they showed slight lowering of the IOP, but this comparison was just done post operatively after a week. We didn't conduct multiple visits, IOP checks at multiple visits. This was just post-operatively 1 week after the drug was given. And interestingly, there was lower IOP, but the statistical results show no significant improvement. No adverse reaction were observed, as you can see, because the sample was small, so we didn't observe any side effect. As you can see, the best corrected visual acuity between the groups at different follow-up visits, you can see a progressive, the log mark means that when the value is decreasing, it signifies that the visual acuity is improving. So we observe improvement in the visual acuity. The group which received the bevacizumab was slightly superior to the diclofenac group. Injections, same injections were given in the two groups. 10 patients received 2, 30 patients received 3 injections, and 4 patients received 4 injections in 6 months duration, depending upon whether the response was there, worsening, or any other complications. Central macular thickness, definitely at the baseline and different follow-ups show a slight decrease in the central macular thickness in both the groups. However, statistically, we didn't observe any significant difference between these two groups. Baseline IOP is comparing it with 1 week post-injection. We want to see that whether there's any raised intraocular pressure, any no change in the IOP or any decrease in the IOP, and we observed quite a low IOP in the intravitreal diclofenac group as compared to the bevacizumab. We couldn't explain what was the cause. It may need a lot of further exploration. This was not our main variable of the study, so we didn't go for that much. So the conclusion that this new agent, which is well-known anti-inflammatory agent, and it's a non-steroidal agent, it means it doesn't possess the intrinsic side effects, complications that we normally encounter with steroids in the form of raised IOP and cataract formation. So this is not associated with it. It's a quite safe drug. We need to explore it further to see whether it's going to replace this drug because it's cost effective, patient adherence is good with this drug, easily available, and we can utilize this as an anti-inflammatory agent. So that's all. Thank you. This is the citation of the article which was published in Al-Shifa Journal of Ophthalmology, and you can see further insight into this article. Thank you.
So by definition, we all are familiar that entropion is the inward rotation of the eyelid towards the globe. This is our classification. We will discuss the senile part. So this is orbicularis, which is the main protector of the eyelid, divided into orbital and pelvic part. The pelvic part then divided into preceptor and pretarsal, and this is the two parts of the pelvic pretarsal and preceptor. These are all relevant regarding the pathogenesis of entropion. These are the locations of the lateral and medial horns, medial and cancer tendons. The lateral cancer tendon attached to upper and lower tarsal plates and then to the vertebral to vertebral deep to the septum. Detachment of the lateral cancer tendon is associated with distraction of eyelid away from the globe. These are all relevant in the pathogenesis of entropion. The medial can similarly attach to the frontal process of the mechanism and then connects to the medial canthus and the medial part of the orbit. It supports the medial canthus as well as position eyelid and globe in their respective position. This is the inferior rectus from give rising to the inferior asan muscle. So the lower leg detectors arise from the inferior rectus muscle, and they consist of capsule fascia and inferior tarsal muscle. The pull of these detectors depresses left and down gaze. So the pathogenesis all depends on these relative anatomy. The vertical stability of the leg is provided by the lower leg detectors, while the horizontal stability is because of the medial and lateral canthal tendons. The weakness of the orbicularis is with age is associated with overriding of the pretarsal by the preceptor orbicularis. So these are a few anatomical factors leading to involution and entropion. We are all familiar with this. Horizontal depth because of the canthal tendon and vertical because of the lower leg detectors. So we are familiar that it mainly involves the lower limb, senile entropion, and these are signs and symptoms most familiar forearm body and sacroiliac spasm, and associated with all these complications, body scarring. So management of the enteropian depends upon two major factors: horizontal laxity and the medial cancer tendon laxity. Horizontal laxity is assessed by the pinching test. We pull the lower lid down and see how quickly it returns to the normal position, and then observe is how quickly it comes back to the north towards the blow. We observe the speed of the return as well as the distance from the corner to the posterior margin. If it exceeds 10 millimeters, then there is horizontal laxity. Then these are the grades which are relevant to the management of this enteropian. Quick snapback means there is minimal or no laxity, or slow return mild laxity, incomplete return moderate, or if there is incomplete return or even after blink there is severe laxity of the lower lid. Because all management depends on these factors. This is how the snapback test is performed. You just release the lower lid and then you measure how quickly, and this is distraction test to assess how quickly the medial lateral cancer moves from the location. This is the flow chart assessing how horizontal laxity depends on the treatment. If there is mild to moderate laxity, and the patient is unfit for surgery, we go by averting sutures. If they are willing, we can offer these procedure or lateral transition. If there is still a significant laxity, and if the medial cancer tendon by dissection test is lax, we have to fix the medial tendon or do medial canceroplasty. If the lateral tendon is lax, we go for stabilization of the lateral tendon or lateral tarsus snip. If there is still laxity of tendons, we can offer quick cut procedure, or for recurrent, we can go for Jones procedure. So these are for how averting stitches are done, passing from the conjunctival side and stitching on the skin surface. So we are familiar with full thickness discs, splitting and insertion of averting sutures. So this is full thickness transformation and passing of averting stitches, and then they are tied over the skin surface. So this is a video of the lateral tarsus snip. The lid is split and the lateral tendon is identified, refashioned, and the stitch is performed as in the lateral tendon and attached with periosteum of the lateral orbital wall. So I am very quick because there are a number of videos. So if there is significant laxity after tendon are fixed, we can assess their assessment of the tendon. If they are lax, we can fix the tendons. We can stabilize the medial cancer tendon by passing a stitch from the medial side of the conjunctiva and tying over with the periosteum of the lacrimal cusp. This is how medial canceroplasty is done. We give an incision medially or expose the medial cancer tendon in passing a stitch in the cancer tendon and stitching to the periosteum, the medial orbital wall. Lateral cancer tendon sling is similar to lateral tarsus, but the stitch is passed through a button hole in the tendon from the upper lid. So this is lateral canceroplasty. Lateral cancer is exposed, then it is refashioned, and again the stitch is performed in the lateral cancer tendon attached to the periosteum of the orbital wall, lateral orbital wall. This is quick procedure. It is full thickness just like these, but there is also horizontal lid split along with aortic stitches. For recurrent, we can do Jones procedure by exposing the inferior tendon and passing stitch through it. If the patient is unfit, we go for cross-leg.
Thank you, Professor Tariq sir. Now I
to be presenting, especially in front of my mentors and my seniors, whom I respect a lot. I'm going to take it away from the last speaker, and I'm really glad I'm presenting after you, sir, because this is just a step forward to what you were just saying. I have got two back-to-back presentations, so I'm going to take not 5 but 10 minutes in amalgamating both my presentations within the same Alright, so we've discussed at length about the marvel of OCT, and this image never ceases to amaze me. It's because the center colored image there is what I saw as a first year student on a cadaveric sample on a microscope, under a microscope. And the image that follows or is at the background is now what I see on my patient with the snap of a button while he's alive and sitting in front of me. So OCT has gone a long way into helping us observe the retina as it is and understand retinal pathology and disease. Now, the way I've seen most people approach Am I Alright, so the way I see most people approach OCT in a busy OPT is there any fluid or not? And if there's fluid, well, we'll inject, and if there isn't, well, we'll just leave the patient there. And sometimes it doesn't stop even there. What is the diagnosis? Mota. But with the experience I've seen, that if you just look at the OCT close enough, long enough, and just kind of concentrate on what it's telling you, it actually unravels a lot more about retinal pathology than just the basic diagnosis. So diabetic macular edema, if you look at it closely, can tell you all of this. You can see cystoid spaces just by looking at this image and say, all right, he's got edema, I need to do something about this. But if you look closely, then you can see the configuration, the number, size, distribution of the cystic spaces, hyperreflective foci. Is there any exudation there or not? Is there subretinal fluid? And all of these different features have their own different bearing. Pick up that there's a slight variation between the characteristics of the one above and the one below. And just looking at it in a little bit more detail. Again, 3 different cases of diabetic macular edema. On surgery examination, they may seem the same. But you've got what we call dysognization of the retinal inner layers in the first image, and you've got these hyperreflective dots. Dysognization of retinal inner layers tell you, without an FFA, that there is an indirect sign of ischemia in this patient. And that, in turn, tells you that there's going to be a suboptimal response to your anti-VEGF therapy. So when you've got drill, then you do look into the element of ischemia in that patient. And that, if on day 1 you're able to explain to the patient and give him this discussion and let him know, we're not expecting 100% result. And there's a lot of ischemia in the eye as well, which is distorting the retinal inner layers. And we're going to start treatment. Of course, we have to treat the edema, but we're not looking at you going back to 6/6 anytime soon. This saves you from a lot of heartache and frustration post 3 injections, say, or post 5 or post 6. Again, you see that there's breaching and exudation within the intraretinal cystic spaces. Sometimes this leads to a prolnectar sign, which is the precursor for hard exudate formation. So you know where things are going. Studies have also correlated hyperreflective intraretinal foci with the HbA1c of the person. So the more intraretinal dots you're seeing, the higher is the glycemic index of this patient. And when you start to see this sort of atrophy in your in between the cystic spaces and coalescence of cystic spaces so that they try to span almost all the retinal layers, you're reasonably sure that this edema has been left untreated for a fairly, long period of time. That again leads to chronicity and a guarded response to treatment. Subretinal fluid in diabetic macular edema has been proven, evidence shows that there's more of an inflammatory component to this macular edema, and there are studies that say that this patient may respond better to a subtenon injection of steroids